Good morning, everyone, and welcome to our call. Today is an awesome day, special day. This is our HP call, and on this call, we generally learn medical issues, talking to doctors, calling on doctors, and when you decide that you want to embark in calling on doctors and talking to doctors, it's important to understand what doctors are going through on their daily basis in their daily life with their patients. And some of the main diseases out there are metabolic syndrome and diabetes. And in particular, diabetes, as we know, it's a really bad disease. I think it's become a little desensitized in our country, where people don't really understand how bad of a disease that is and how it really just turns your entire metabolism upside down and wreaks havoc on your body. And today we have Dr. Czer, board certified internal medicine, critical care specialist, dual certified, and he's going to teach us a little bit about diabetes. And I haven't seen his presentation, so I'm not sure where he'll go, but I'm sure we'll have a Q&A at the end as well. And hopefully we all walk away understanding not just about diabetes, but also how we can play a role in helping this disease, reverse this disease. And also, how do we work with patients maybe who have diabetes, because it is such a symptomatic disease, and medications will need to be altered fairly quickly when they do our program. So it's going to be a really good talk today. So Dr. Czer, thanks for being willing to share with us today, and we look forward to learning from your expertise.
Well, thanks, Gary. This kind of came about because several of our coaches, and Joanna in particular, have been approaching HPs and being referred, and also on their own getting clients who have diabetes. And so it's raised some questions about, and some anxiety, I think, in terms of how good candidates are these clients and patients for our program, and a little better understanding of diabetes to increase people's comfort. So that's what we're going to talk about this morning. Let me share my screen and get some slides going here. One sec. Share screen. And then, okay. So does everybody see a big slide here? Can you see that, Gary? Oops. For some reason, I'm not hearing anybody.
Okay. I was on mute. I could see it.
Oh, okay. Now, sometimes the slides don't fit on your screen, but if you go to the top and under View, you can change it to Fit to Screen. So if your computer, for some reason, is only showing part of the slide, you can change that. So let's get going here. So we're going to talk about diabetes and Take Shape for Life Optavia. So let's start simple, and this is as simple as it's going to get. What is diabetes? Well, diabetes is a disease of elevated blood sugar in its form. But interestingly, people don't die from elevated blood sugars. The elevation of blood sugar causes a whole host of issues in the body, particularly vascular inflammation. And so most people these days actually in the medical field think of diabetes more as a vascular disease than strictly a endocrine or blood sugar disease, because people have dramatically increased risk for heart disease, heart attacks, strokes, and other complications. Eye disease is also vascular, so it's one of the more common causes of blindness. These days, the most common cause of kidney failure, and so a whole host of organ damage, particularly related to blood vessel inflammation because of the high blood sugars, ultimately what causes a lot of the morbidity and mortality associated with diabetes. So how does this all work? So blood sugar in our bodies is regulated by insulin, which is a hormone produced by the pancreas. And almost every cell in our body has receptors for insulin. And when they're stimulated by insulin, it causes the cell to take up glucose and either store it or metabolize it. And that's kind of where the ultimate problem with diabetes occurs, as we'll get to in a sec, is that storage and metabolism. There are basic two types of diabetes, and I'm sure anybody who's got a diabetic has run across this. The typical type 1 diabetic is what we call juvenile onset, or they've had onset of diabetes early in life. And that's caused by what is felt to be an autoimmune disease, where your immune system attacks the insulin-producing cells and destroys them. So those people actually have very little to no insulin production themselves. But the more common type of diabetes, and the type that we deal with in adults all the time, is type 2 diabetes, or adult onset diabetes. And if you measure insulin levels and production in those folks, they actually have very high insulin levels, and they've developed a state of insulin resistance related to genetics, weight, diet, and lifestyle, and we'll get to all those factors in a sec. So type 1, type 2, but just to confuse things, to let you know, some type 2 diabetics actually burn out their pancreas because after a while, the pancreas just kind of gives up trying to produce so much insulin, and they kind of become more type 1, where insulin levels start falling. And then the other confusing thing is some physicians and specialists classify anybody who's on insulin as type 1. So that kind of confuses it. Even though they're adult onset, they call them type 1 if they're on insulin. But really, in terms of our discussion, I only really consider type 1s and the people who we have to be really careful of with our program, of the juvenile onset type 1s. If it's an adult onset type 1 that somebody classified as type 1 because they're on insulin, they're still excellent candidates for our program. Juvenile onset type 1s, though, we have to be really careful about because they are very, very brittle, very, very sensitive to insulin, and not great candidates. And frankly, most of the time, they don't have as much of a weight issue as the type 2s. So how do we get here? So let's talk about diet. You may or may not know this, but before the 1800s, before the development of refinement of sugar, the average adult human consumed about 2 to 3 pounds of sugar per year. Fast forward to today, the average adult consumes over 72 pounds of sugar a year. And so our metabolism, which has been developed over thousands of years, isn't really designed to handle that much sugar. And then the second factor is carbohydrate intake. The current recommendation, if you look at it, for total carb and sugar intake is about 140 grams a day. But the US average is somewhere between 300 and 400 grams a day. And so what we've done is totally overwhelm our systems and ability to metabolize and deal with that sugar and carb load. And the important thing to note is that all carbohydrates is a storage form of sugar. And once a carbohydrate hits your stomach, it's broken down into its simple sugars and absorbed as sugar, not as carbohydrate. So all carbs become sugars and just add to the sugar load. And the other factor is weight. And there's actually a genetic factor involved here. As weight goes up, the risk for diabetes goes up, but it also varies by genetic background. African Americans aren't as at risk for diabetes with weight gain as other racial groups. If you take a typical Caucasian person, their BMI goes up by 5 points, they double their risk. The risk goes up for diabetes 100%. If you're Hispanic, you're even at higher risk, it goes up by about 125%. And the highest risk folks are Asians and Pacific Islanders, where the risk goes up by 145%. And a lot of doctors now are seeing a lot of Asian folks that really aren't obese. They may be just a little bit into the overweight range with BMIs in the 25 to 27 range, but still be diabetic. And if those folks can get down into the mid 22 kind of BMI range, their diabetes will go away. So Asians and Pacific Islanders and Hispanics are very sensitive in terms of weight and diabetes. And it's felt partially related to the fact that all fat cells have insulin receptors, and as the fat cell gets bigger, as it's storing more fat, it develops more insulin receptors, and those insulin receptors kind of suck up the insulin that's being produced and make the body resistant then to insulin, or need more and more insulin to deal with the blood sugar. And then the third factor is lifestyle. And if you go back a couple hundred years before the Industrial Revolution, people were much more active. And sugars or muscles only burn sugar, which was cool because if you consume sugar and you're very active, you just burn it up in the muscles. But modern life is much less active, and so we burn up much less sugar in our muscles. And lastly, modern life has more stress and people tend to sleep less, both of which increase the level of stress hormones, which cause a state of insulin resistance. Now, it's nice to know that exercise burns stress hormones, but since we're less active, so all these things kind of feed into each other in terms of making and contributing to insulin resistance. So all three factors, diet, weight, and lifestyle, play a role in insulin resistance and the onset of diabetes. Now, we've all, I think, in the course of our Take Shape for Life experience, seen this insulin response curve of, how we tend to eat with these very high glycemic diets, causing dramatic rises in blood sugar, which keep our insulin levels high on the upper bar. And then if we go to more complex carb, lower glycemic meals, we can reduce those spikes in blood sugar and dramatically reduce insulin. And that is how Take Shape for Life can dramatically help our clients with diabetes. Let's talk a little bit about glycemic index, because that is a question I get sometimes, is what's glycemic index? Well, glycemic index measures basically how similar or close to a sugar a carbohydrate is, or how quickly it releases its sugars into the bloodstream. So by definition, sugar has a glycemic index of 100. And just for reference, if you look at white rice, especially the white sticky rices, they have a glycemic index of 90. It's almost like eating sugar. In fact, the enzymes in our saliva breaking down rice into sugar before you even swallow it. Brown rice, on the other hand, has a glycemic index of 40, so much lower release of sugar into our bloodstream. White breads, glycemic indexes in the 80s, whole wheat breads more 45 to 55 kind of range. So more whole grain type stuff is much better. So lower glycemic index diet. And the importance of carb loads. Let me try to get something out of my way here. It's occupying part of my slide. Is that those high glycemic index foods and large carb loads cause too rapid a rise in blood sugar, and that kind of overwhelms the cell's ability to uptake and store sugars. We store sugar as glycogen, and a cell only has a limited capacity. The analogy I like making for insulin resistance and carb loading is kind of like if somebody comes to your door with a cupcake and says, "Oh, here's a cupcake," you eat the first cupcake. If 10 people show up at your door and say, here's 10 cupcakes, doesn't matter how encouraging they get in terms of you eating the cupcakes. At some point, there's a diminishing return on how many cupcakes you can eat, even if there's 100 people standing at your door saying, "Here, eat my cupcake." So we develop resistance to eating cupcakes. Well, same thing with cells. As they get fuller and fuller with sugars and have stored all they can store, it doesn't matter how much insulin is floating around. They at some point say, "I can't store any more sugar," and blood sugar level rises. And then what happens also in the liver is if it can't store anymore, it actually will change metabolism to convert sugar into fat or triglycerides. And then that's stored, which is why people gain weight. So insulin itself is a growth hormone, and eating all these carbs puts us into a fat creation and storage mode. There we go. And so, what's the correct nutrient balance? And I think that this is a slide from Dr. A's Habits of Health, which I think we've all seen, where we talk about in maintenance, we want people to be eating about 50% vegetables, fruit, 25% protein, 25% starch, basically to dramatically reduce that starch intake. A couple things to note here. One is especially for diabetics, corn, I no longer consider a vegetable. It's all sweet corn. It's a carb. And then what we talked about in terms of glycemic index, simple way to look at it is for carbs, brown is good, white is bad. Simple. For fruit, berries are best. They have the most antioxidants and the least sugar. But it's important to note what the serving size of fruit is, and this is particularly key for diabetics. A serving size has always been defined as 1/2 cup of cut fruit. That's not a very large serving, and a couple servings a day. For a diabetic, 2 servings max, only 1 with each meal. So that's like a half a banana, half an orange, half an apple. So smaller serving size. And then this kind of holds for everyone, and that is eat, don't drink your fruit. Takes about 6 to 8 oranges to make a glass of orange juice. That's about 12 to 16 fruit servings. That's not for a healthy diet. And then, of course, lean proteins. So that's great for maintenance, but how do we get there? So let's talk a little bit about how we diagnose diabetes. The test that we primarily use is the glycohemoglobin, which is sometimes referred to exactly as that, or the hemoglobin A1C. So you'll hear your clients or patients talking about their A1C or their glycohemoglobin. That is referring to the same test. And what that reflects basically is what your average blood sugar has been for the past 2 months. So normal is 5.5 or less. Borderline diabetic is between 5.6 and 5.9. Early diabetes between 6 and 6.5. Well-controlled diabetes under 7. Controlled under 8. The goal in most metrics is we want all diabetics to be under 8. And so poorly controlled is anything 8 or above. You can also diagnose it on a fasting blood sugar over 120 or a 2-hour after meal sugar over 150. That's more used in terms of pregnant women, but you'll hear those numbers too. But the A1C glycohemoglobin, that's the primary test that we use. And you'll hear your patients refer to when they're talking about how well controlled they are. And what they like often is to get it under 7. Under 6.5 is wonderful. So what you want to do is memorize this slide and you'll know everything there is to know about diabetes. That's a little joke. I'm putting this up there just to show this is the most recent 2017 treatment algorithm for type 2 adult diabetes from the American College of Physicians. And I don't want you to start writing all these different drug types down, but what I primarily wanted to get to is just kind of this first line here, and that is the monotherapy. What is the basis of treatment? You'll see on the right side, in all levels of diabetes management, lifestyle management is there. The medicine that is typically used as the baseline for any diabetes treatment program is metformin. The nice thing about metformin, you'll see there in the loop, is it does not cause low blood sugar or hypoglycemia. So you don't have to worry about metformin on our program. You don't really need to adjust it or worrying about them developing hypoglycemia. But almost any other medication, pill-wise or insulin, can cause low blood sugars and will need to be adjusted while patients are on our program. But most doctors are pretty keyed into this. Particularly, they know all these algorithms have lifestyle management, but they don't have any program. And that's where Take Shape for Life Optavia is a real advantage to physicians these days, because we're all under the gun in terms of metric monitoring now, and the future of payment medicine is one of the metrics is how well controlled are our diabetics. And if they're not on a lifestyle program, it's very hard to do it for most patients with medication alone. So lifestyle interventions are kind of the 3 things I talked to before. And that is, weight's a factor. So attaining a healthy BMI and maintaining 19 to 24, low glycemic, limited carb diets, perfect for our program. And then lifestyle things of moderate exercise, to increase the amount of sugar that's burned by muscles, and then minimizing stress and getting adequate sleep to minimize stress hormones, which also cause insulin resistance and raise blood sugar. So our comprehensive lifestyle program and fuelings are perfect for diabetics. So as I alluded to before, who's a candidate for our program? Any diabetic is a candidate except a true childhood or juvenile onset type 1, because they're very, very brittle. And the only thing with those on insulin is they do need pretty close monitoring. We have an endocrinologist who specializes in diabetes on our team as a health coach, and her approach to her diabetics is on day one, she cuts their insulin by 50%, and that seems to work perfect. Other physicians I've noticed over the years are more hesitant to follow that advice, and so they often want their clients to start at a little bit higher calorie intake and not so dramatically reduce their carbs on day one. So we often will start them on like a 4 and 2 or 4, 2 and 1 and move them to a 5 and 1 over a few weeks as they're in relation with their doctor lowering their medications and insulin. So like I said, for the pills, metformin does not cause blood sugar, but other medications will need to be adjusted. And then let's talk just a little bit about insulins, because you'll hear these terms thrown around. If you remember on that slide that showed the eating and the changes in blood sugar and insulin tends to have a consistent baseline level and then spikes when we eat. And so when we put people on insulin, replacement insulin to boost their insulin, we try to duplicate what the body does. So we usually start people on what's called a basal insulin that produces a very smooth release of insulin over 24 hours. And that typically, the most common one is called Lantus. So you'll often hear the patient say, I'm on Lantus. Like, what's Lantus? Lantus is this smooth release over 24-hour insulin. And then the other type of insulin are rapid-acting insulins to cover the sugar rise with meals. And the most common ones there are Humalog and Novolog. And so you'll often hear people just say, I'm on Lantus and Humalog. So long-acting and short-acting. Now, the reason that we need to adjust insulin is that insulin requirement is strictly related to carbs. And one of the ways we frequently tell our patients to adjust their rapid-acting meal insulin is to start with a scale of 1 unit for every 10 grams of carbs that they take in. Well, if somebody's eating, if they're averaging 300 or 400 carbs a day and averaging between 50 and 80 carbs per meal, they're going to be taking 5 to 8 units of their mealtime insulin. But if they go to Take Shape for Life and they are eating a meal replacement with 11 to 14 grams of carbs, clearly they don't need as much insulin. They're going to need to reduce their mealtime insulin. So that's where the adjustment needs to be made, is they need a lot less insulin because their carb intake is dramatically less. If some patients are sophisticated enough that they monitor this very closely, and so they can make the adjustment themselves, but other patients and clients aren't that sophisticated, and their doctors just tell them to take 3 units or 4 units or 5 units or whatever with each meal, and they don't adjust it. So those are the patients who will need to be in close touch with their doctor and adjust their insulin intake, as their sugars will fall dramatically. So let's talk a little bit about starting diabetics. So obviously we want the doctor to be in the loop, and sending a letter to the doctor discussing our program and what it entails is very useful. In fact, I'd like Joanna actually just went through this process with the physician, gave him the letter, and then got feedback. So maybe as soon as we get done, I can ask Joanna to share a little bit about how that went. And Greg and Whitney have a standard letter that they sent out with a packet the HP packet that has a letter in it. It's a little too long. I think it needs to be shortened, which we did. So I think it works well. And then make sure that they have instructions from their doctor on how to deal with low blood sugars, because that's not our job as a health coach. Even myself as a physician, if I have a client of another doctor, I'm not taking over the role of adjusting their medications. That's the doctor's responsibility. I'm just coaching them on program. So often they'll say, well, oftentimes it's the medical assistant or nurse who deals with the day-to-day issues with medication adjustment. So they'll say, well, just call, Susie if you're having low blood sugars, and she'll work with you on your medications. So the key point there is don't start diabetics on the weekend because the office is closed. And they're not going to be able to reach their doctor or the staff in the office. So probably the best time to start diabetics is like on a Monday, so that they can, if need be, get in touch with their doctor's office and be in touch with them about adjusting their medications as blood sugars fall. And that's sort of a basic outline. So be happy to handle any questions or things I didn't cover that you have questions about. And I'll stop sharing and go back to the view.
I have some questions, Dr. Czer.
Okay.
Do you want me to talk about that form first, though?
Yeah, that'd be great.
Okay. Okie doke. So Dr. Czer helped me make this form, one-page form, because I asked him, when diabetics go in to start program, they need to get approval from their doctors. And I noticed a lot of diabetics not only have a primary care physician, but they have a diabetes doctor as well. And
Right.
so I was trying to come up with a form that we could either give to the pre-client to take into the doctor, or I can fax directly. So what happened with this client, she's in Oklahoma, diabetes 2. She's not really, doesn't understand email and all that. So what I did was got all the information of her nurse practitioner, her primary care physician, and her diabetic doctor, and just basically sent this one-page document letting them know that their patient wants to embark on our program. And I'm asking them permission is basically what it says. So-and-so would like to go on a program with your approval. I'd like to start them on blank date. And then it just goes on and it has all my signatures and all my information on there. So what I did with this particular patient, like I said, she doesn't do email very good and all that. And I couldn't get this form to her to hand deliver it. I got all her doctor's information in their faxes, and I sent it one fax out to the nurse practitioner and then one fax out to the diabetic doctor, because I knew she was going to go in that day. And so I said, okay, I faxed it to them. You make sure you go talk to them about it. And it worked out perfectly. She went to both doctors, and then she calls me back last night. She's so excited. She's like, and one of my doctors, they said that his wife even lost 60 pounds on this program. So she's so excited. And so it couldn't have worked out more perfectly, Dr. Czer. So that's what I did. I emailed it to him, so I have email. But, and in a different situation, I guess we could maybe give it to the patient to hand carry it. I don't know, but it worked out beautifully for me. We're just, so she's ready to start program. We're waiting for her to come back from vacation, and we're going to make it happen. I was just a little bit embarrassed because when I started my in-laws on it and they're diabetics, I didn't know what to give them. So I don't know if this is unprofessional or what, but it was my in-laws. So I handed in the diabetic guide and kind of circled the 4 and 2 plan for dad and circled that, and then said, go talk to them like that. And of course, they said, okay. And they started program, but I wanted something a little more professional, I guess. And this just worked out perfectly for me 2 days ago. And so she'll start program when she gets back on vacation, and she's so excited. So.
Yeah, and we can probably share that form, people, if they want it. I basically took Greg and Whitney's physician letter form that they have, but the issue I had with it is it's like 3 pages long, and no doctor is going to read a 3-page letter. And the second part is it tells them what test they should order. And that's, I think, stepping a little bit over the bounds. Most doctors know what test they want to order for their diabetics. So we basically took all that stuff out. We basically just took the middle portion of the letter out and used what they had. So we didn't create anything new. We made it more abbreviated and succinct.
Mm-hmm.
Dr. Czer?
Uh-huh.
I got a magazine the other day, and it was a health magazine, and on the headline said 2 out of 3 people are pre-diabetic, and then the headline below that was 9 out of 10 don't know. How does that?
Yeah, I mean, I think that's a little bit of an exaggeration. The statistic that I saw recently was that 1/3 of the U.S. adult population is pre-diabetic or diabetic.
Okay.
And I don't know about 90% of them don't know, but I mean, it starts with it's a spectrum all the way from early onset metabolic syndrome all the way into diabetes. But no, it's a major health issue, and most physicians are getting overwhelmed by all these pre-diabetics and diabetics.
Are there any questions or symptoms that they would be having that we might want to be aware of?
No,
pre-diabetics.
That's kind of the problem. Is it's asymptomatic. I mean, in the old days, before we were better at proactively looking for diabetics, especially with the glycohemoglobins. The glycohemoglobin test has only been around for about 25 years. Before that, the only thing we had was sugars. And one of the issues with sugar levels is you send a patient to the lab fasting. Well, they're usually really good in terms of eating the day before they go to the lab. Oftentimes does not reflect what they've been eating the other 99 days out of the last 100 days. And so sometimes fasting blood sugars are misleading. And that's a nice thing about the glycohemoglobin. It's a 2-month average, so they can't hide. So it's like once that test came out, all of a sudden there's like this epidemic of diabetes underneath, and then also with increasing obesity, it's building and building and building. Certain populations, like Hispanic populations, that may be true. I mean, that's like the major health crisis in Mexico right now is diabetes.
Wow. I have a question for Jessie, if I can ask it now. She said, I don't know if I'm going to pronounce this word correctly, but is ketoacidosis?
Right.
Is it ever a concern with any of our plans?
Well, that's why I talked about, and I was pretty specific about type 1, juvenile onset type 1 diabetics. Those are the danger folks, because they have no underlying ability to produce insulin. And one of the metabolic derangements that occurs when insulin's too low is ketones are produced.
Mm-hmm.
And their body can't metabolize the ketones, and it produces an acidic state in the body, and they develop this condition called diabetic ketoacidosis, which can be life-threatening.
Okay.
And so you don't want juvenile onset type 1 diabetics cannot go into ketosis. We never want to put them in ketosis. So they're not a candidate for the 5-in-1 or the 4-in-2.
Okay.
So that's I don't, but there's not that many of those.
Okay.
Frankly, and you'd have to, if they're overweight, which a lot of them actually are underweight. So weight is less of an issue with type 1 typically, but if they are an overweight type 1, they would probably need something like a 1,500 calorie type plan, and their endocrinologist would be working daily with them to make sure that they don't go haywire.
Okay.
So those are the really tricky ones. The type 2s, diabetic ketoacidosis is not an issue.
Okay. And then I have another question, if I may. How often should I tell my clients to check their blood sugars, and why? Because right.
Yeah, I mean, I don't like getting into the telling them when they check their blood sugars. That is kind of the responsibility of what their doctor should, when they check in with their doctor,
okay,
they're going on this plan, the doctor should be telling them that.
Okay. So I really don't need to be asking them, like, tell me what.
I would just make sure that they are checking it, but frequency and that sort of thing, that should be outlined. And that's one of the things I would recommend everybody check with So did you talk to your doctor? Yeah, I talked to the doctor. Did they tell you to check your blood sugars? How did they tell you, make sure they're checking you more often than they were? Some people check them once a week. Well, that's not going to fly.
Right.
Yeah.
So really, we're not responsible saying, hey, give me your blood sugars, etc.
We should not. You're coaching them on the program. Their doctor is coaching them for their diabetes.
And then my one diabetic.
Can I jump in on that real quick, please?
Yeah.
Only because, Greg, I'm just curious about this because I actually don't do that. Obviously, I have a little bit more knowledge. I respect that. But I'm not diagnosing them. But what I am aware of is that when they do this program, if a doctor doesn't know about this program, then they don't really even know what to do. I've experienced that before as well. And so what I recommend people do, and this is not a diagnosis, I recommend they check it daily because this is a symptomatic disease, but they need to report the numbers to their doctor, not to me.
Yeah.
But I just say, look, if you got to check it, because if you go too low, I've had people go dizzy, and obviously they think it's the food, and they don't know that they're hypoglycemic. They don't understand. So is that not okay to say, yes, check it? It's like blood pressure too. It's like, you got to check it and then tell your doctor what you see. That's what I usually do.
Yeah. I mean, I think it depends a little bit on your comfort level. I mean, there are some coaches who just really are uncomfortable with diabetes and are uncomfortable getting that involved with it. Obviously I'm comfortable. Obviously, you have more of a medical background as well. I think Joanna's getting more comfortable as time goes on, getting more and more diabetics. But yeah, I mean, they should be checking their sugar daily. If they're on insulin, they should be checking it multiple times a day.
Okay.
But the doctor should, and the nice thing about, in this letter, which I think all doctors, we should send with patients to all their doctors, it outlines how many calories are in the 501 plan, how many carbs are in it, and then a general vague recommendation of many of our patients find that they can reduce their medications within several days, and often insulin can be reduced 50%. Vague, not like you need to do this, but just kind of an overall overview that our experience is this, to sort of help their doctor if their doctor is not that familiar with our program.
Okay, that's awesome to know that. Does typically diabetics take their blood sugar? I'm just overall here. I heard like sometimes people will take it twice a day, sometimes they'll take it 4 times a day. Does that sound like the norm when they do take it?
Well, usually if they're on medication pills,
only pills,
they'll check it once to twice a day before fasting, before breakfast, and then a second time maybe before dinner.
Okay.
Or if they're on mealtime insulin, they have to check it every time they eat a meal, because the sugar level, they not only take insulin based on how many carbs they're going to eat, but also what their sugar level is. If it's high, they take a unit or 2 to bring it down. If it's low, they may subtract a unit or 2 from their carb calculation. So if they're on mealtime insulin, it's adjusted with every meal, and so they're checking it up to 4 times a day.
Gotcha. That's helpful. I'm so glad to hear that, because that's so helpful. Thank you.
I think one of the keys that I learned with diabetes is that, when you look at it from a patient perspective, it's diabetes and high blood pressure for our program they're the 2 most symptomatic diseases. And that's the reason that if they have both high blood pressure or diabetes, that they need to be in contact with their doctor, because as they drop their water in the beginning, that's like going on a diuretic. And so their blood pressure could drop fast. And if they're already, what I've learned is if they're already controlled, you don't have to ask these questions to them, but if they're already controlled with low blood pressure, but they're on 4 meds and they go on ours, they will go hypotension very quickly. And so, I've learned that, you don't have to get into all that, but if they're on those, if they have high blood pressure and they're on meds, or they are diabetic and they're on meds, the key is that they could go too low when they do our program. And that's the reason that we need them in contact with their doctor very quickly about those 2 diseases, right? So the doctor can appropriately adjust medications.
And that's, again, why I suggest starting these folks on a Monday. not on a Friday. because the covering doctor on the weekend is not going to appreciate getting a call from a diabetic with a blood sugar of 45.
Right.
They're going to tell him to eat more. They're going to tell him to eat more carbs, and that's not going to help.
Right. How often?
Yeah,
I'm sorry, go ahead.
Sort of a little anecdote here. Since I do the doctor's call for Take Shape for Life on Wednesdays, we had a call one time of a very frustrated coach and client because they kept calling their doctor because their blood sugar was going low, and the doctor kept telling them to eat more carbs. Not lower the insulin, eat more carbs.
That's almost sick, right?
Right. So I was kind of like,
just shows you the nature of
like, well, I'm not sure I would quite do it that way. Let's look at this logically. If your blood sugar is lower, maybe you should take less insulin. So the upshot of that one is that the client was going, I think maybe I need to go to another doctor.
Yeah, and the other thing I would add to that is it shows you the nature of physicians' mindset, and
right.
They're so entrenched in the medical that I have tools to help you. Don't worry about what you do out there. I have tools, and they're not thinking that other way.
Right. Even though this patient wanted to lose 50 pounds, tell him to eat more carbs.
Yeah,
more calories and carbs.
Like, yeah, that's doesn't sound like a smart suggestion to me.
Dr. Czer, so I have a good friend, and she's going to be on and off partially on the program. She was like a type 2 diabetic, not really controlling it well. She's one of those that became a type 1. So if I could encourage her to do the program completely, would she fall under that 4 and 2? Because she does check her blood sugar minimally 4 times a day, if not more often.
Yeah, so so this is why. So if I'm the doctor for that patient and they came to me, my advice to them would depend on how sophisticated they are in managing their diabetes. So if they know to adjust their insulin based on carb counting, and so they know they take 1 unit for every 10 grams of carbs, and if they know they're going to decrease their carb from 40 grams a meal to 10, and they're going to decrease their insulin from 4 to 1, then they can go on the 5 and 1. But if they're not that sophisticated and they're just on a set, like take 4 units with every meal, which I have some diabetics who are like that, they're going to need to go intermediate, because if you drop their carb that dramatically, they're going to go hypoglycemic and not know what to do. So that's why the doctor kind of needs to get involved. And so on this one client that Joanna has, the doctor actually said, I want them on 14 to 1,500 calories to start. Great. 4 and 2, 4, 2 and 1. So we'll start it, once the doctor is familiar with that, then depending on the rapidity of weight loss, then we may try to lower her calories, letting the doctor know down the road a little bit.
I had to bounce off of that question. My next question is, how often should we, because in that letter that we made, Dr. Czer, how often should I send them a fax and say how their patient is doing? Once a month, once every 2 weeks? I know it varies with each doctor, what would be your recommendation? Because it's kind of vague here. I think I wrote here that, I can't remember what I wrote, but it says on here somewhere where it says I'll follow up and, give you information as needed and such. So what would you recommend me updating and faxing them? How often?
I would say after 2 weeks.
Okay.
For a couple of reasons. One is they're going to need to have adjusted probably their medicine. 2, the results are pretty dramatic usually at 2 weeks in terms of, the first 2-week weight loss is pretty cool, and the patients are pretty darn excited about that losing so much weight because they never were able to accomplish that before. And then, maybe a comment in there about, whether, how they're doing with their blood sugar management, because after 2 weeks, it may be a good idea to get back in touch with their physician.
Okay, so but you're not saying I'm going to say anything about their blood sugar situation. I'm just emailing them, letting them know how much weight they've lost. Is that correct?
Well, I mean, if the patient or the client's telling you that, oh, I
Yeah,
keep having a problem with low blood sugar, I would put that in the follow-up
Okay.
with a subtle hint like, maybe we can decrease the medications further since they've lost 14 pounds or whatever, or 10 pounds. So yeah, after a couple of weeks, I think that would, and then once a month after that should be fine.
Okay. Thank you.
Hey, Dr. Czer, there's a couple of things that I experienced when I worked with a lot of diabetics. That was kind of our target market when I did the pilot. We said, when I heard the studies about how well we treat diabetics, that's who we went after with Michelle's practice, just to see like if it's true or not. And one of the interesting things I found, I was curious if you could speak to this, is if a person is a newly diagnosed diabetic within 5 years or so, then we seem to be able to reverse their disease pretty good with nutrition.
Yep.
If they were like an uncontrolled diabetic, even though on those 5 years we were okay, but like if they were like 20 years down the road, they've had it forever, their beta cell function's now so bad that no matter how good their nutrition is, their sugars still seem to be erratic. And have you experienced that as well? Like I couldn't get some of those people under control no matter what we did. And these were like, I've been a diabetic for 25 years. I never took care of myself. I was obviously uncontrolled. And then there just seems to be like, they're just shot. Can you speak to that at all?
Yes. So, yeah, like I said, you know, the confusing thing here is some type 2s eventually exhaust their pancreas because their insulin requirements like 2 to 3 times what the pancreas should be producing because their carb intake is so darn high that eventually their pancreas goes, I give up. I'm not making any more insulin. And so, insulin production starts falling. So depending where in this whole disease process you intervene does depend on how well the pancreas can bounce back. If it's in the first 5 years and they're not totally out of control when they're diagnosed, then the pancreas can recover and insulin sensitivity can return to normal. In fact, sometimes very quickly. And so, yeah, what you said is very true. In those first 5 years, we can often get them off all their medications. Their fasting blood sugars are normal. Their A1C goes down to 4.9. I've seen that happen multiple times. But if their pancreas is totally exhausted, I don't know if I would say that they're unstable, but because we can usually reduce the medications, usually their blood sugars improve dramatically. The A1C falls, but we can't get them off medication completely because the pancreas is just too far exhausted.
Is that what you were referring to when a type 2 kind of becomes a type 1? Is that what that is?
Yeah.
Oh, okay. That's what it really means is they become a type 1. Now they're insulin dependent no matter what.
Yeah. I mean, I don't like that when people do that. Oh, I'd become a type 1 because they're not really a type 1. Their pathophysiology is type 2. It's just that they've exhausted the pancreas. Because
right. They're not classified type 1, but they're insulin dependent, which I guess is part of a type 1 classification.
Which people say, oh, yeah. So there's nothing wrong with being a type 2 on insulin.
Right. Right.
That's why I refer them as an insulin dependent type 2. But yeah, there is that confusing nomenclature out there that we need to be aware of.
Absolutely. And I do know this, for those of you who are calling on physicians you got to realize one thing, that when you call on physicians, what you're going to get most of the time are people that have diseases. That's the nature of working with physicians, but that's what we're here to do, is to try to help people overcome some of these diseases. So it's a noble thing to do. But targeting the diabetic patients is a wonderful way because a lot of patients are diabetic. And so even asking the doctor to, ask that box 8 question, how ready are you to undertake to help get your disease under control? If they can ask all their diabetics that question, 20% of those diabetics are going to be ready to hear more right now. And so you'll get a lot of leads. They'll be diabetics. They're a little bit more complicated, but really not that much after you get through the first couple of weeks and they understand how to utilize the doctor and the medication. Then they just become a regular client who you can alter the disease state in the course of their life dramatically, because diabetes leads towards early cardiovascular disease and death.
And and I think those patients often are a little more motivated because there's often a family history of diabetes, and their mother or their father in the old days, had complications from diabetes, and they saw that when they were growing up, and so they don't want that for themselves. So oftentimes they are a more motivated group. Some of them, just like other patients who have weight issues, just figure, it is what it is, and there's nothing I can do about it. Well, yeah. We can't help everybody, but certainly the people want to be helped, we can help.
Right.
Which is the importance of making sure you do your best to influence the doctor to ask that question. How ready are you to take on some lifestyle changes? If they don't ask that question, then the doctor's never given solutions before, then the patient most likely might not ask the doctor. So if the doctor finally has a place to refer, then you want to influence him to ask that question, and obviously leave it up to the patient to make that decision whether they're ready or not. But you want to influence him to ask that question. And then what I would also recommend, which I don't think I've shared so heavily before, because our program, I feel, is so broad, right? It's pretty much anyone is benefits who has diseases. But when you go into physician offices, you don't want to be so broad, I don't think, because it's too big. And so you do want to identify some patient populations that you want to target. So one of them could be diabetes. So you want to talk to him about diabetes, learn enough about it and how our program can help it. You want to target maybe metabolic syndrome. Those are the pre-diabetic people. They see a lot of those. 50% of their patients are probably classified in that category of metabolic syndrome. Target yourself to a population so when a doctor is seeing a patient, he can identify that patient with you, versus if it's too broad, it's too broad for him too. Dr. Czer, do you agree with that? Because that's what we were always taught, and that's what I've heard from even physicians. What do you think?
No, I agree with that. In fact, one of the physician leaders of Take Shape for Life, Mark Nelson, actually I'm supposed to talk with him in just a couple of minutes here. He has changed his orientation, that their group is primarily focused right now on metabolic syndrome, prediabetes, and diabetics. Just because they're saying, that's half the patients anyway, so let's just keep the doctor laser focused. And he seems to be getting a lot of traction with that. So yeah, I agree.
Awesome. Well, we want to thank you so much. It is 10 o'clock. This has been a very fruitful conversation. I think everyone learned a lot. Dr. Czer, thank you for sharing your wisdom and your expertise in this disease state and how we can help benefit. And we'll get this recording out and watch it again and again so you can remember a lot of the things Dr. Czer said, because when you talk to physicians, it's best if you can speak their language, in a obviously not a condescending way ever, but it's best to be able to speak their language so they know that you've studied, that you have knowledge, that you're not just, some person who doesn't know. Because if they don't trust you, you're not going to get referrals, right? So
and I think they can also tell if you feel comfortable with the topic of diabetes, because they know that's a challenging group for them. If you approach them and saying, yeah, we can treat diabetics, and you come across as knowledgeable and comfortable, they're going to be much more willing to send folks your way. In fact, they'll be excited to send folks your way because they're happy. Yeah.
I think they will. And I would, from my experience, pay really close attention to the end of this talk when it came to understanding if they're a newly diagnosed versus a 5-year diabetic versus a 20-year diabetic, because that's the kind of conversations you can have. Dr. Newly dosed diabetics, we can help them if they're willing to learn how proper nutrition. We'll coach them on this program. We can reverse that, right, with nutrition. It's been proven, and that way he starts to know that you know your stuff, right? He needs to know that you know your stuff and that he can trust that he can actually refer his diabetics to you versus a diabetes educator, right? And so it's a wonderful population, and you will transform the country because the less diabetics we have, the less cardiovascular disease down the pike. And so that's definitely a disease state, and metabolic syndrome to go after. Those are the two disease states I go after. So I concur with Dr. Nelson that it's half the patients, and they can identify them, and they're all the future cardiovascular disease risk patients anyway.
Right.
Awesome. Well, thank you guys very much for joining. Dr. Czer, thank you very much for your expertise. We will go ahead and end this recording.